Good morning, dear friends, and welcome to this IC on target Emmetropia, refractive cataract surgery. So, as all of you all know, today cataract surgery has become a refractive procedure, and patients' expectations are quite high, and they require freedom from glasses once they undergo cataract surgery. And basically, the success of cataract surgery is judged depending upon its refractive outcome. So, it's a refractive cataract surgery, and so you need to be very precise. So, with this in mind, we have designed this course so that we cover aspects of various devices for biometry, different formula, and when and where you can use these formulas to get an accurate outcomes, and also the newer lenses, toric IOLs, which can take care of astigmatism, and newer devices like the intraop abrometry, which of course very few are there in India, and we have Professor Jagatram to speak about it. And this will help both beginners and advanced surgeons to obtain the best results after cataract surgery. So without further delay, we will start with the first speaker, Dr. Shreyas Ramurthy, who will give an overview of the biometry devices.
Good morning, everyone. And at the outset, I'd like to thank Dr. Sri Ganesh sir for inviting me on his course. And it's always a pleasure to be a part of his session. So I will be taking you all through an overview of the biometry devices. And like sir was saying, today the combination of biometry devices and advanced biometric formula is what is really making cataract surgery into a refractive cataract surgery. And truly, we have a variety of choices today. And as we speak, more and more devices are getting included into the market. So I'll try to present an overview, try to give some of the concepts, while I will not be able to cover the entire gamut of devices. So we have ultrasound biometry, optical biometry, and topo and tomographers, OCT based biometers as well. Now, ultrasound biometry might sound as if it is extinct, but even today, a very well done immersion biometry can give extremely accurate results, a well done keratometry. I keep mentioning this every single time when I'm given this topic, that there are still a few centers of ours where we don't have an optical biometer. But all those centers still do toric IOLs, multifocal IOLs, and their results are comparable to those of the centers where we have optical biometers. So it's important that we use only immersion, don't use a contact technique. Ensure your spikes in your scan are good. You should have those specific 5 spikes required. And once you have a good quality scan, also you can use in help in adjusting the gain. Use a higher gain when you have require a lower resolution, like for example in denser cataracts where you just need the axial length, can decrease the gain if you have a lot of reverberations, like in a silicone oil filled eye. So by making some of these adjustments, fine tuning, ensure you have a specific biometrist who does this. Even by using an ultrasound biometer, you can have excellent results. The only challenge comes when you have a very high myopic eye, where you have a staphylomatous eye, so where the visual axis and the anatomical axis does not coincide. So you might be measuring into the depth of the staphyloma, which will end up in overestimating the IOL power. Whereas with the A scan, because the patient fixates, you are measuring more or less over the fovea, and we'll talk a little bit more about it. There have definitely been advances with the IOLmaster 500 to 700 and Lenstar 900. And essentially, what is happening now is most of these are now turning into B scan biometry. That is, you are able to get a cross section using swept source OCT. You are able to measure the lens thickness, anterior chamber depth very, very accurately. So I'll take you all through each of these components, starting from keratometry. So with keratometry, while manual is still stands, can be used as a reference, but more or less we have switched over either to the optical biometers for accurate keratometry, and there is excellent agreement between all the devices. So whichever one you have, you can be happy using it. Tomography is also very useful, especially in post LASIK eyes. And irrespective of the tomographer which you're using, Pentacam, Galileo, Sirius, all give excellent outputs. Pentacam has a specific EKR report as well, which can be used in post LASIK eyes. But specifically coming back to the biometers in terms of keratometry, it's important that you know the number of points and the area which is being measured. because all the formulae that you have are based out of our biometers on the central 3 mm. So sometimes if there is a discrepancy between your SIMK values on your topographer and your IOL master, you would rather go with your IOL master because the formulae are actually adapted to the readings which you get from the IOL master or the lens star. So specifically regarding IOL master, one additional advantage that you have is something called the telecentric keratometry, where essentially it's a little more idiot proof that even if the patient is not cooperating very well, or the person who's taking the scan is not doing it accurately, even if the focus is not spot on, the distance between the spots remain the same. So the area over the cornea where you're measuring remains the same. The zone remains the same. So even with minor discrepancies in terms of the patient not being able to position their head properly, you'll still get accurate scans. But what has really been a game changer is the presence of total keratometry. Now, the total keratometry is essentially giving us a torus model where we are able to project the points which we're using for measurement on the anterior cornea onto the posterior cornea to get a posterior torus fit as well. And therefore, we get the traditional anterior keratometry, you get the posterior keratometry, and the sum total, which is the total keratometry. We all know now that the posterior corneal power and astigmatism have a great role in terms of our IOL power calculation. And the best part with the TK is that you have formulae which are adapted to the total keratometry, and it does not require any modification and change to using other formulae. So you can use the ULIP compatible formulae. There has been argument on whether you can take the measured value versus a value which is mathematically already available on the online calculators. And it was earlier shown that the mathematical values were superior to the measured values taken from any of these Scheimpflug devices like Pentacam, Galilei, which also give you posterior corneal astigmatism. This is primarily because the values taken from these measurements are not directly suited for the formulae which we are using. So whereas with the Barrett TK formula which is available now, you can use the TK provided by the biometer, and you can use them in the Barrett TK Universal 2 or the Barrett TK Toric, which gives you excellent results. And I think in all our practices, most of us have switched over to using these for all our patients. And definitely it has improved our outcome in toric patients. And even in post-laser refractive eyes, rather than using the overall calculators, we've moved on to using the Barrett 2K TK, which is giving us better results than the Barrett 2K or the ACRS average or Shamas. And it is not just the Barrett TK, but also the Haigis TK, which is performing very well. So primarily that the total keratometry is giving us more accurate measurements of the posterior cornea, which is now compatible with the formulae which we are using. And whether you're using the Haigis or the Barrett, excellent results are available now. You also have angle alpha and angle kappa measurements which are provided. And as far as keratometry is concerned, definitely this is the way to go. Quickly moving on to the other measurements, the anterior chamber depth measurements, while are very, very important now because the ELP, which is central to most of the formulae which you're using, is also corely dependent on the anterior chamber depth measurements. The earlier IOL Master 500 used to measure from the epithelium. Now you have the option of using the endo or the epi as well. The earlier iterations were not very accurate with pseudophakic eyes, but now with the B-scan biometry, you have excellent measurements with the IOL Master and lens star as well. The axial length, again, very good, strong intermethod agreement between different devices. Even with the ultrasound, if you can see here with the immersion, the difference is only 0.04 millimeter difference. So it's very, very good. The best part about the swept source OCT is apart from just looking at the fixation. Now, if you have a patient who's not as cooperative, but here you can also image the foveal pit. This makes it even more accurate because you know for sure whether you're measuring at the right point. When the foveal pit is imaged properly and you have good fixation, you can see that the readings are extremely repeatable and the IOL power is exactly the same. Whereas wherever the foveal pit is not visible and it's not imaged appropriately, you have a difference in keratometry as well as in axial length, which gives rise to almost a diopter of difference in the IOL power between readings. So by imaging the foveal pit accurately, you also get very, very repeatable and recordings, which can be used for all your patients. Again, better ELP measurements, like I mentioned, both in the pre and post-operative period, because you get better anterior chamber depth measurements. It also gives you a kind of faint image. It's not a replacement for your OCT, but then when you see some macular pathology, you instead of directly counseling the patient for other premium IOLs and then getting an OCT done, this will kind of give you a initial idea whether this patient is a possible suitable candidate for premium IOLs. The penetration of these web source OCT devices is also much better, and it's very few cataracts nowadays that you're having to shift to the immersion. Most of them we are able to do with the optical biometer. The most recent advancement is combining the biometry with the topography, and we have a variety of devices nowadays, right from LS900, the Aladdin, which is very useful. We have it in a few centers. The IOLmaster 700 also gives you a very simple Placido image. The Galilei G6, Zima, Tomy, Argos, again with excellent penetration, and the Pentacam AXL. So some of them were primarily Scheimpflug devices, which have now incorporated axial length, and the other way also, where the biometers are now giving us a simple Placido device image. And multiple studies have compared different devices, that is the Scheimpflug devices, which provide the axial length, versus the classic biometers, and they have found that the results are quite comparable, and you can use any of these devices. This is just a sample printout of the Aladdin, where you get a reasonable normalized axial map. You also get the different keratoconus screening indices, the pupil data, Zernike analysis, all of which in a single image. And it's extremely useful even in regular corneas as well as irregular corneas, in keratoconic eyes and post-LASIK eyes as well. And this is just a printout from the IOLmaster 700, where you can see that it is quite comparable. Even though the measurement data points might be fewer than the Scheimpflug devices, it's quite comparable and gives you a fair idea. Almost all our patients now, we are running them through the Barrett toric calculator. Even if you find that there is very little astigmatism on the anterior cornea, the posterior corneal astigmatism can contribute. And you will be surprised to see that even sometimes as low as 0.5, 0.6 on the anterior cornea, it will suggest a T3 model. So it's good to run them through your calculators. So with excellent imaging devices and with the availability of fifth generation IOL power formula, which I think we'll hear in the next talk, Emmetropia for any and every patient has become a real possibility. Thank you so much for your kind attention.
Thank you, Dr. Shreyas, for that excellent coverage of biometric devices. And though we have technology advancement and then newer devices coming in, like he said, if you cannot afford these devices, you can still use immersion biometry. And many of the formula are available online.
Yes,
like with the APA CRS, you have the entire Barrett suite. So you have access to that. So you can use the correct formula to get an accurate result, even if you have an immersion biometry. So with that, we will go on to the next talk, which is IOL formulae, which and when, by Dr. Sanjali Vadokar, but she is actually giving this talk instead of Dr. Gaurav Luthra, who is unable to come for the AIOC. Dr. Sanjali was our fellow, and now she is in practice at Pune, and she will speak on the IOL formula.
Thank you, sir. Thank you, Dr. I would like to thank Dr. Ganesh sir and AIOC for this wonderful opportunity. I would like to acknowledge Dr. Gaurav Luthra sir and Dr. Sheetal Brar ma'am for few of the slides and the material for this presentation. So I'll be talking about IOL calculation formulas, which and when to use. So the quest for accurate intraocular IOL calculation has been there since the first IOL was implanted by Dr. Harold Ridley sir in 1949. Now today, as sir said, cataract surgery is just not cataract surgery. It has become a refractive surgery, where the patient expect the post-operative outcome to be between plus and minus 0.5. Coming to calculation formulas generation wise. So the first generation formula were by Dr. Fydorov, and they were based on the theoretical model of the eye. It was based on a schematic model of the eye, and they were not very accurate to predict the post-op outcome. The second generation formula were based on regression analysis, where the analysis was done based on the post-operative outcomes which were deduced. The third and the fourth generation formula were widely used even till now, and they give fairly accurate results. They are based on Virgin's formula, which is based on the Gaussian optics of the eye, and it is a combination. It's not a very precise classification if we divide it according to the generation, because some of the formulas they are Virgin based, and some are a combination of the Virgins and theoretical formula. These newer generation formulas, some of them are based on like such as Barrett's Universal 2, Hill RBF, and Super LADAs. They are based on ray tracing models and artificial intelligence, which gives us a fairly accurate post-operative outcome these days. This is an overview of the summary of all the L-power calculation formulas. Here we can see that the earlier generation formulas were fairly precise in the normal axial length, whereas during the extremes of the eye, they did not give a very accurate results. When we come down to Barrett's Universal 2 and Hill RBF, they are fairly accurate to the extremes of the eyes as well. The version formulas were classified into two variable, three variable, four variable, five variable, and seven variable formulas. The variables included were axial length, keratometry, anterior chamber depth, lens thickness, horizontal white to white, age, and refraction. So briefly talking about the IL calculation formulas, the SRK T was a holy grail till now, till the newer generation formula came into picture. It was a theoretical approach to alpha calculation formulas, and it used optimized post-operative anterior chamber depth. It also included retinal thickness correction factors, corneal refractive index, a combination of Hoffa-Q, Holiday 1, SRK-T, and SRK-T worked really well for 22 to 24.5 length of the eye. SRK-T is still used in many of the centers when the IL power is not able to, we are not able to calculate the IL power using the IL master. And it gives fairly accurate results. A combination of, it is recommended for eyes for more than 26 mm. And the Hoffa-Q, it was a very popular formula for pediatric surgeons. It used personalized ACD, which depends on the IL style. The axial length and corneal curvature, it is used to predict the ELP. ELP is the position where is the state where the IL it sits in the eye, and it's the most important thing to calculate during when we look at the IL calculation formulas. It is recommended, Hoffa-Q, it is recommended for eyes less than 22 mm. Holiday 2, it uses 7 factors. It was also very popular till Barrett's Universal 2 came into picture. And Holiday 2, it is recommended for long and short eyes with Van Cox adjustment. So the most popular formula, that is Barrett's Universal 2, it's a Virgin based. The model of the eye in which anterior chamber depth is related to the axial length and keratometry. The A constant and lens factor, they are also used to determine the anterior chamber depth. It is applicable for all types of eye, short, normal, long, and for all types of IOL. And it is also available online, so it is easily accessible for most of the surgeons on APACRS and ASCRS websites. It can also be used for post-refractive surgery and toric calculation. The parameters that are required for calculation of Barrett's Universal 2 are axial length, keratometry, and lens factor. These are the must-have data. The optional parameters are anterior chamber depth, wide to wide, lens thickness, and design factor. Barrett's 2, it is incorporated in ILMaster 700, which includes 3 formulas, that is Barrett's Universal 2, Barrett's Toric, and Barrett's True K, which is used for post-LVC calculation. Barrett's suit, it is based on a nomogram, and calculates the posterior corneal curvature based on that specific nomogram. The lens factor, it is in the Barrett suit, it is calculated using SRKT constant. The design factor is IL specific, and it influences the IL calculation. Without design factor also, you can calculate the IL power, but it is potentially less precise. Talking briefly about Olsen C and other formulas, Olsen C, it is based on a concept called a C constant. It is a fraction of the lens thickness by which the center of the IOL will locate itself post-operatively. Hill RBF, it is also as accurate as Barrett's Universal 2, and it is based on a precise set of data. If it is not able to calculate the values that you have put, it will give you a value such as out of bounds. It means that they don't have the data for which you are trying to calculate the IOL. Superlada's formula, Kane formula, Evo formula, they are the recent formulas which also work really well. So coming to specific like short eyes, long eyes, post refractive surgery eyes. For short eyes with less than 21 mm, Hoffer Q was fairly accurate, but now most of the people prefer Barrett's Universal 2 as it gives more accurate results. There was a study done by Hill RBF in 2016, which was a prospective study for axial length less than 22.5 mm. It said that Hill RBF, Hoffer Q, Barrett's Universal 2, and Olsen, they almost gave, all of them gave accurate result for axial length less than 22.5 mm. For longer eyes with axial length more than 25 mm, such as patients with posterior staphylomas, status post-scleral buckle, congenital glaucoma, and ROP. This is a nomogram which told that more than 26 mm SRKT, Olsen P were more accurate. With Bangkok adjustment, most of the formulas work fairly well, but in the end, Barrett's Universal 2 is one formula which suits all of the eyes. For post-corneal transplantation, we can do a primary implantation at the time of the surgery, or we can do a secondary implantation after 6 months after the cornea is healed. The primary implantation is done by using the keratometry of the other eye or using a standard keratometric value of 3.5 diopter. The secondary eye implantation is more preferred as it gives lesser refractive surprises. Keratometry by topography can be done using aphakic mode. A refractive version formula, they work well for post-cornea transplantation. For keratoconus, as we know, it gives hyperopic refractive surprises post-operatively. Here, Haig's Hoffer-Q SRK2 formula work well. So to summarize, SRKT formula is recommended for long eyes, whereas Hoffer-Q is recommended for short eyes. The fourth generation formulas, such as Hill RBF3, Barrett's, Haig's, Holiday 2 formula should provide highest accuracy in full range of axial length. We would prefer Barrett's Universal 2 and Hill RBF3 for most of the eyes. Thank you.
Thank you, Dr. Sanjali, for that overview of IOL formulae. And next, we will go on to a very advanced topic, that is intraoperative aberrometry pros and cons, by Professor Jagatram. He needs no introduction, but right now he is working with the Grewal Eye Institute. He was Professor and Dean of PGI Chandigarh, and there they had the intraop aberrometry, and then he has had some experience with the intraop aberrometry, and he'll be sharing it with us.
Thank you, Dr. Shri Ganesh, for giving me this opportunity. I will be speaking on intraoperative aberrometry pro and cons. Real-time analysis allow this adjustment of IOL power intraoperatively, and we use the infrared light and interferometry. Analysis of the data from the central 4 millimeter calculate the IOL power. What are the benefit? What are the pros? It can be effectively used in myopia, post-refractive surgery, placement of toric IOL, even axis, whether any further rotation required or not, and in many of the other situation, even in such as radial keratotomy and other patients. But the problems are that this is not suitable for short eyes, where intraocular pressure is low. If there is central corneal opacity, even lid speculum will also produce some problem, and if patient is not fixating. So I will be showing some of the video. This is normal cataract, 60-year-old, where we planned that we will place multifocal toric IOL. This video is about 5-6-year-old. Once we remove the cortex and then we fill the anterior chamber and capsular bag with viscoelastic and do aura. And this is the power. But already we have done the power with IOL master and other modalities, but we match whether it is the same or it differ, but it is very accurate. So we have done even comparison of this aura with the other modalities. This is another small video. This is in a pediatric cataract. It is a classical zonular cataract. Roughly we have already marked the horizontal axis. After removal of the cortex, we fill the capsular bag and anterior chamber with viscoelastic. Pressure should not be low, but then we adjust it and see that what IOL power comes. Because child is under general anesthesia, so we have to make fixation much more accurate and it gives IOL power. But in children, we have to adjust the IOL power under estimation. That is what you have to do. This is here we are using Callisto. As Callisto is also found to be accurate, and then we see whether any rotation of the IOL is required or not. It says NRR, means no further rotation required. And then comes in some of the other condition where there is a radial keratotomy. Because when we started doing it, it was a question of comparing it with the other modalities. Incisions are adjusted between the radial incisions. Main incision and side port incisions, depending upon where there is a more space or where it is required. And then performing a phacoemulsification in the eye. Again, this procedure remains same for any type of the eyes, but particularly in radial keratotomy, particularly if there is a central haze, there is a corneal opacity in the center. In this patient, it is a clear visual axis, so no issue, no problem found. but otherwise it may not even measure it. Fixation is extremely important, and here it shows 31 diopter power. So more than 30 diopter comes in only few of the IOLs. These are the RK patient who has most of the time post-operative residual hypermetropia. So that has to be corrected, or it appears to be little more accurate compared to other formula. So in conclusion, intraoperative aberrometry is a newer technological advancement which is useful tool in patients with extreme of the keratometry or many of the post-operative situations. Thank you very much.
Thank you so much, sir, for the very elaborate talk. Up next, we have none other than Dr. Sri Ganesh, who's going to talk about the toric IOL calculations and perfecting the outcomes. While sir is getting set up, sir, a quick question to you, sir. While using the Aura, I mean, I know it's an expensive device, but that apart, how do you ensure that the amount of viscoelastic which is filled in the eye is comparable to the physiological IOP and we don't overinflate and underestimate the IOL power?
One of the, if it is a low pressure, it will not even detect it. So yeah, it has to be adequately filled, and then if it comes, you have to adjust, uh, and if it comes still low, you can inject more. So gradually you have to inject, but if it is over is also not more, it is also not fine. So it is a note, I think. First, we were also trying it, that how much to fill, but uh, it comes with the experience that it should not be low, it should not be very high, it should be just appropriate.
Another question I wanted to ask you, sir, how do you account for the effect of the lid speculum?
Yeah, that is very right. I think there should be no pressure. There should be no pressure. It should not be very tightly placed, or type of the speculum also matters. So that also gives false. That will give, I think, some problem in estimating the power. That I said in the problems associated, that if there should be no undue pressure on the globe.
So we'll go on to toric IOL implantation, mastering toric IOL implantation. Again, it's very important to manage astigmatism during cataract surgery, and one of the main reasons for dissatisfaction is residual astigmatism after cataract surgery, especially if you're using a premium IOL like a trifocal or a multifocal. Your astigmatism has to be within 0.5 diopters, otherwise the results would not be optimal and the patients will not be happy. So if you look at what are the pain points for a toric IOL implantation, these are the issues you can face for a toric IOL implantation. The first is biometric formula, which to use. Second is marking of the axis itself. Third is implantation and alignment of the lens. Fourth is implantation in small pupils where you can't actually make out the markings on the toric IOL. And the fifth is the rotational stability post-op. So let us deal with all of these one by one. Biometric formula, you have to use a formula that considers the posterior corneal astigmatism. And if you previously, they were not, the importance of the posterior corneal astigmatism was not known until Cock brought out his study and the Baylor nomogram, which suggested that for with the rule astigmatism, you can go one step lower and undercorrect, and for against the rule astigmatism, you kind of go one step higher and overcorrect the astigmatism. And then now you have most of the formulae with taking into consideration the postercorneal astigmatism, because this has a huge influence on the outcomes of the refraction. And most of the online calculators now available with different lenses incorporated the postercorneal astigmatism. We prefer to use the Barrett TK toric formula, which is available with the IOL Master 700, and we find this to be very precise because it truly measures both the anterior and posterior curvature of the cornea. And the Barrett TK not only takes care of the postercorneal astigmatism but also looks at the ELP, which can have an influence on the outcome. So if your lens is more anteriorly placed or posteriorly placed, then the toricity, correction of the toricity will vary. Coming to the next problem of marking of the axis, you have various markerless systems available today which are quite precise. You can mark the various devices like gravity markers or bubble markers, or you can even mark on the slit lamp manually. You can mark the 180 degrees axis and then use a Mendes marker for placement of the IOL on the correct axis. But today we have various markerless systems, the Callisto from Zeiss, the Varion from Alcon, and you also have the lasers which incorporate um, in the capsulorhexis itself, they incorporate markers to place the IOL. For example, the Intelli axis with the lens AR, which we have. So if you look at the lens AR system, it's very advanced. It takes the pentacam, and according to the astigmatism on the pentacam, after scanning the eye and matching the reference image, you can see that you have two marks on the capsulorhexis tags which are there, which actually indicate where the lens has to be placed. And this is, we are also using a Callisto markerless system to verify, but I will show you where the marks are, and you can see that here very clearly. You can see the tags in the capsule. Sorry. So you can see the tags in the capsule there, and you can very precisely place the lens. So the advantage is there is no parallax error like the image guided systems, and again post-operatively you can check whether the lens is aligned when you dilate the eye, because these tags are there on the capsulorhexis. Coming to implantation and alignment, what we have found that implantation under BSS gives rise to less rotation of the lens, and it is very good to leave the eye a little softer during at the end of the surgery. So if you look at this, I am doing an implantation under BSS. So I fill the antechamber with BSS, hydrate the sign port, and then I don't use an irrigating cannula because it is a closed incision. I just inject the lens under BSS, that's a wound assisted injection, and then just push the trailing haptic, and then I use the markerless system to kind of align the lens. And you can see that there is a fold in the posterior capsule. That shows that the eye is a little soft, and there is no viscoelastic. See, the eye is a little soft. Now if you overhydrate the wound, you will see that this disappears. And now the capsular bag is open, so there is a higher chance of rotation. Even if there's some retained viscoelastic, then what happens is immediate post-op, the IOP increases because the retained viscoelastic, and the bag opens up and the lens can rotate. So it's always good to, I find, to inject under BSS and leave the eye a little soft, so you can see this fold in the posterior capsule. I call this the all clear sign, and this actually reduces the incidence of rotation. We did a study to evaluate this, whether BSS versus OVD, there is any difference. And we selected 100 eyes of 100 patients, 50 in each group, and followed them for 1 year. And this is a comparison of rotation. So you can see the blue group is the BSS, and the amount of rotation was minimal in the BSS group, 0 to 5, 82 of the eyes, and then 5 to 10 again lower, less, more than 10 minimal, only 2 eyes. When you compare it to the OVD group, the OVD group had a higher amount of rotation. So probably this is the mechanism, because the IOP goes up You can't remove, especially if you're using HPMC, you can't remove the HPMC completely. Some amount of residual HPMC can increase the IOP, open the bag and cause rotation. So the other problem is in small pupils. So for this, I have what is known as a Ganesh toric IOL marker. This is available from Epsilon. It's got two windows and a blunt blade in the center. So I mark that, and you can see this is a toric IOL. You can look at the marks through the windows. You can look at the toric marks through the windows, and then you press down on the lens and you indent the lens. So this causes a temporary indentation and marking right in the center. So the problem is in small pupils, you can't see the peripheral mark. So once you keep it down for about 30 seconds, then you get a nice indentation and a mark. Then you can load the lens. In the regular cartridge, and you can still see the mark there. Then this is a mid-dilated pupil. So I'm injecting the lens into the capsular bag, and I have the Callisto image guided system for placement of the lens axis. So you can see that the mark is still visible. Sometimes you may not see the peripheral marks clearly. If you don't see the peripheral marks, again you have to handle the iris, you have to retract it, look at the marks. You don't know at the end of the surgery. And by about 2 minutes, this kind of mark disappears, but it's there long enough for you to align it. And even if the ink disappears, you can still see the reflex on the lens, and you can see the indentation, and you know that it is on axis, it is placed on axis, though you cannot see the peripheral marks. So this is the advantage, and this is a post-op eye trace which is done, which shows that the lens is perfectly aligned. We also use the HD analyzer post-op to look at any scatter, whether it affects the optic of the lens, but post-op you cannot see any scratches or marks, and the OSI also is very good, so it does not change the quality of vision. Coming to rotational stability, it can be a problem, especially in larger bags, larger axial length. So I have a swivel haptic IOL. These are capsulotomy fixated IOLs. So when you fix the lens onto the capsulotomy, you have the Femtis also, which is available, and this is the Ganesh swivel haptic lens. So you place the toric lens on the axis and then rotate the swivels to capture the capsulotomy. So you make a capsulotomy of about 4.5 millimeters. Then you capture it so that you can see that it is on axis, and once it is captured, then it will not move. And we have done studies now, and we find that it is very stable and no rotation. You can see that's the post-op, zero sphere, zero cylinder. Intended axis was 104, and post-op it's perfectly stable, because irrespective of the bag size, there is no rotation of the lens. It is anchored to the capsulotomy. So these were a few points. Of course, this lens has been patented, and we are doing the clinical trials, and it should be available in a couple of years, both the non-toric and toric versions, and this will help reduce the rotation of toric IOLs. So these were a few points to which I wanted to share on how you can improve your toric IOL results and get better outcomes. Thank you very much for your attention.
Great talk, sir, and wonderful tips. And while Dr. Sheetal is just getting set up, just a quick question, sir. I mean, this swivel optic design we've seen in the previous videos as well is very impressive. Does it mean that once the swivel is, while we are manipulating, placing the swivels, there might be a small chance for the IOL to rotate while we are manipulating? Once the swivel goes out, we should not rotate the IOL? It's already catching the capsule? Okay.
It's not that you cannot adjust it. Like you saw in the video, I went below. With the Femtis, what happens is you need femtocapsulorhexis, a very precise capsulorhexis, and once you capture the lens, then you can't go below the lens. So if you have any retained viscoelastic, then you can have an IOP rise. But whereas with this lens, even with a manual rhexis or a femtolexis, if it's around 4.5 mm, you can capture the capsulorhexis, and you can go below, remove all the viscoelastic. You can make some adjustment, but what happens is it is anchored, so it does not easily rotate, and it is quite stable.
Great.
So,
there appears to be more rotation if there is a residual viscoelastic.
Yes.
I think your study also showed that, no?
Yes.
That
so that's why I like to inject under BSS. I don't like to use viscoelastic.
So that is a that is a nice study which shows that if it is very viscoelastic, there may be more rotation, particularly higher rotation.
And the very important tip there is where many of us use the irrigation cannula inside and then inject the IOL, but that is only suitable for push type injectors. You can't use for screw type. But this tip of hydrating and then just directly going can be used for any type of injector.
Any type of injector, yes. See, because in an open kind of a situation like SICS or ECC, you need the chamber to be maintained by viscoelastic, otherwise it collapses. Here, if you are doing a wound-assisted injection, there's no way the BSS can escape from the eye until you inject the lens completely, and it remains stable, and it works very well in my hands, at least, and this is what I've been doing for a few years now.
Wonderful, sir. So next we have Dr. Sheetal, who's going to talk on post-refractive surgery IOL power calculation.
Thank you, Dr. Shreyas, and I would like to thank Dr. Sri Ganesh for this wonderful opportunity. Good morning, friends. I'll be talking about post-refractive surgery IOL power calculation. This can be daunting sometimes, and this is a bit of a theoretical topic, so please bear with me. So there can be three types of errors that may be causing problems with IOL power calculation post-LASIK. The first error is the instrument error. The second error is the refractive index error. And the third is the formula error. So instrument error basically refers to the error which arises from the use of standard keratometers. So what happens is when you use standard keratometers for corneal power measurement after LASIK is that these instruments cannot accurately measure the corneal power post-refractive surgery because the keratometers essentially measure the paracentral points at 3.2 millimeter zone and they miss the central flatter zone. So we know that post-refractive surgery, especially the myopic surgery and also hyperopic, the maximum change in the cornea occurs in the central 3 millimeter zone. So this is the area which is kind of not measured accurately, and hence this can lead to overestimation of the corneal power and a resultant hyperopic shift. Refractive index error. Basically, again, if you use keratometers and topographers only to measure the anterior surface of the cornea, and they basically convert the radius of curvature to diopters using this formula. And the refractive index which is used in this formula is 1.337, which is a fixed refractive index to allow contribution for the posterior surface. Now, basically, this refractive index is used when assuming a normal or a constant relationship between anterior and the posterior surfaces of the cornea. Now, after refractive surgery, this relationship changes because the anterior surface flattens and there is no change in the posterior surface. So, this refractive index does not hold good, and hence you can have errors with the IOL power calculation. Formula error is basically the error that arises due to problems with calculation of the effective lens position. Now, following LASIK, corneal curvature changes, as we all know, and due to this, the effective lens position can be wrongly estimated. Now, the third generation formulae which we are using, like the SRKT formula, Hoffer Q, Holiday 1 formula, basically these formulae, they calculate ELP. Basically, the ELP in these formulae is dependent upon the change in the curvature, and also they depend on the axial length. So since the curvature changes, it flattens. So these formulae estimate the position of the IOL much more anteriorly, and hence they suggest a lower powered lens, which leads to hyperopic surprise. And it has been found that 1 millimeters of error in effective lens position can result in up to 1.5 diopters of change in the final refraction. Now, what are the methods to obtain true corneal power after refractive surgery? So, there is clinical history method, which is still considered to be the gold standard, contact lens over refraction method, topography based post LASIK adjusted keratometry, central ring topography method, and net corneal power measurement. So clinical history method basically was proposed by Holiday in 1989, and here basically how you derive the central corneal power is by adding the mean keratometry power before surgery and the spherical equivalent before refractive surgery, and then subtracting spherical equivalent which was there after the refractive surgery. So this theoretically yields the actual corneal power, is also easy to calculate. However, the accuracy depends upon the accuracy of the data. If you do not have pre-refractive surgery data, then you cannot use this, and it is also not suitable for the RK eyes. The contact lens over refraction method was proposed by Ridley. And in this method, basically, you calculate the corneal power as the sum of the base curve of the contact lens, the power of the contact lens, and the over refraction minus the spherical equivalent of the manifest refraction without a contact lens. Now, this is inexpensive method and is also suitable for both post LASIK and RK corneas. However, it suffers from the disadvantage that its accuracy reduces with the poorer visual acuity and is also not suitable for denser cataracts. Then we have the topography based post LASIK adjusted keratometry. Now, in this, basically, the true corneal power is predicted using a single central post-op reading on the topography machine. And under this category, we have the Koch and Wang formula and the Sharma's formula. These formulae are available on the ASCRS website. So these formulae are regression formulae based on LASIK data and hence are also not suitable for post-RK eyes. Then we have the central ring topography method. This is the method which is suitable for post-RK eyes. So it averages the topographic corneal power of the central 3 millimeter area. And when you apply this with the double K formula, it gives excellent predictability. Then you have the net corneal power measurement that takes into account both the anterior as well as the posterior corneal surfaces. And this is useful when you do not have any refractive data available. So you can use the pentacam or you can use the optical coherence tomography methods. The true net power in the pentacam is the one which is most commonly used. So now what are the different IOL power formulae that can be used post refractive surgery? So you have this very famous formula, which is the double K formula proposed by Aramberry. So in this, basically, this is done to improve the accuracy with the third generation formulae. So as I said, that third generation formulae depend upon keratometry and axial length for ELP estimation. So what it does is basically it uses the post-refractive surgery corneal power for the actual power calculation and the pre-refractive surgery corneal power for the ELP prediction. So and you can have these adjustment tables or the correction tables which are available on the drhill.com from wherein you can derive the IOL power calculation. Also, the Hagee's L formula, which is also quite useful. This is available as part of the built-in software of IOL Master, both 500 as well as 700. And this is a regression-based formula based on the statistics. So accuracy of this formula may actually decrease if the eye is on the edge of the normal distribution, say a very highly myopic eye or highly hyperopic eye. So it may not be very accurate. It is also based on the LASIK data, hence not suitable for post-RK eyes. And then we also have the Masket formula, which adjusts the power of the IOL using post-op measured data and knowledge of the surgically induced refractive change. Now, online IOL calculators have actually made our life very easy. They are fairly predictable and handy to use. So you can find these formulae on different websites, iol.ascrs.org, ilab.com, the Hoffer program website, and the drhill.com website. So ASCRS website is one of the most commonly used and is a very popular website wherein you can use this IOL calculator for eyes with prior myopic, LASIK or PRK. So what you need to do is that you can enter whatever data is available with you, even if you have any pre-refractive surgery data or not. You can enter all the data, like the refraction, keratometry. Also, if there you have topography, then it also caters to a lot of topography systems, wherein you can have the ISIS, the TOMI, the Galilee, Atlas, Pentacam, even the RT view. So whatever equipment you have, you can measure the cornea, the corneal power, and you can enter the values here. And based on whatever data you have entered, it will suggest IOL power using different formulae, like the Sharma's formula, Hagee's L, and the Muscat formula, etc. Then you also have the APSRS website, wherein you have the Barrett True K formula. This is a very popular formula which works for most of the post-LASIK situations, hyperopic LASIK, PRK, myopic LASIK, PRK, and even post-RK eyes. So this is based on the Barrett Universal 2 formula, wherein it calculates a modified keratometry value for post-refractive surgery eyes, and it also provides a double K solution when the central Ks have been altered. So here you can see that this formula is quite easy to access. And then we also have the holiday EKR detailed report, which is available in the Pentacam. So both post-myopic and hyperopic LASIK eyes, basically you can use this report, and you can use the 4.5 millimeter EKR zone K values, which are here shown in the middle. And these values have been shown to have high correlation with the central corneal power calculated with the clinical history method. So as I said, clinical history method is still considered as the gold standard. So these values in this zone, they kind of correspond with this method. So this zone is selected for K values. And you can also see that there is this graph on the left side. So if you see this peak as a single peak with Gaussian distribution, then the cornea is the keratometry is fairly well distributed, and you can also implant a multifocal lens in these eyes if the peak is a single peak like this. And you need to use a Holiday 2 formula with this report. Then we have the total keratometry. I think Dr. Shreyas has already discussed this. I'll not go into details and how it is calculated. So basically here, you don't have to assume the posterior curvature. You already directly measure the posterior curvature. So it provides better accuracy. The Barrett True K formula can further be improved by use of the TK values. And Dr. Graham Barrett has also found in his study that with the use of this formula, the outcomes had further improved. Then we also have the ray tracing, which is the latest, and we have the MS39, wherein we use the ray tracing. The keratometry basically is measured by the ray tracing, and then what you need to enter is the axial length from your IOL master or any other from the immersion. Also, you need to enter the target refraction, the pupil diameter, and A constant of the implanted lens. So this also has been found to correlate with the, like, it works as par at par with other formulas such as the Barrett 2K formula. So just showing a case, this case had a post-myopic smile 3 years ago, and he had a rapid onset of diabetes, and he developed NS grade 2 in both the eyes. This was his refraction, and this is the pentacam. You can see this is a bit central flattening, which looks fairly regular on the axial map. But when you see the Holiday EKR report, you see two peaks there, so it's not really very regular. So we thought it is better to implant a monofocal lens in this case. And this is the Zanicke analysis. Corneal abrasions were also on the higher side, so we decided to perform biometry for Zeiss CT Lucia, which is a monofocal lens. And we checked with different formulae, and here you can see on the top the three formulae are the third generation formulae, and then the ray tracing, Hagees L, Holiday 2 with EKR, and Barrett 2K and 2K TK. They are all specific post refractive surgery formulae, modern generation. And here you can see that with the newer formulae are actually giving almost the same refractive, same IOL power as plus 22.5. And this is quite different from the older formula. You can see the older one are 21.5, and here the IOL suggested is 22.5. So almost 1 diopter difference. So we went ahead with 22.5 diopters. Post-refractive, post-surgery at 2 weeks, 4 weeks, the residual refractive error was 0.25 diopter of SC. So then we found the predicted post-operative refraction and the predicted error. And with this, we can see that the newer formulas, the error is much less compared to the older formulae. And out of the newer formulas, the Barrett 2K TK has the least prediction error. So to conclude, in post-refractive surgery cases, use more than one method to measure the central corneal power, use more than one formula to calculate the IOL power, It's better to hedge in the direction of myopic results in post-myopic LASIK eyes and emmetropia and slightly hyperopia in the hyperopic LASIK eyes. Total keratometry based formulas provide better and accurate results. However, it is still advisable to warn the patient and counsel the patients about the potential need for refractive correction after cataract surgery, since there are so many variables which are not under our control and refractive results can still be off. Thank you so much for your kind attention.
Thank you, Dr. Sheetal, for a very comprehensive talk. You ran through so many different formulae and calculators. Today, if you were to operate on a patient post LASIK, post SMILE, is there any specific formula or calculator that you would advise?
Barrett-Ruque TK.
So
That's the one formula that works very well for all situations.
So I think things have really become simple for all of us now. I mean, while it's a good idea to have the understanding of the theory and why these changes are required, but now the entire Barrett suite can be used for any type of patient, whether it is post LVC, post RK, or previous different types of ablations. All of them work extremely well with the Barrett-Ruque. We have almost stopped even looking at the ACRS or other calculators nowadays, and the Barrett-Ruque, and if you have the TK with you, the Barrett-Ruque TK works even better, and excellent results that we are able to achieve with them. You are even able to have the confidence to implant multifocal IOLs in many of these patients because the biometry is spot on. So up next we have Dr. Supriya Samak, who's going to talk about managing post-operative refractive surprises, a surgeon who's just as talented as Dr. Sri Ganesh, and we look forward to hearing from her.
Thank you, Dr. Shreyas, for that kind introduction. My name is Dr. Supriya Sri Ganesh, and today I'll be talking about managing post-operative refractive surprises. So when we have a residual refractive error after cataract surgery, we must think why the surprise. So first of all, we must recheck the biometry and make sure that we've used the correct IOL formulae, which was beautifully detailed by Dr. Shreyas. The second thing we must do is correct the cylinders properly with either toric lenses or limbal relaxing incisions. We must make sure that the procedure was done for the right patient in the right eye and to avoid human errors and data entry errors. If you have a minus residual refractive error, we need to make sure that the proper adjustment was done for sulcus lenses, and we also need to consider back distension syndrome and capsular contraction syndrome where the lens moves forward. If you have a plus residual refractive error, we need to consider post-refractive surgery IOL power calculations and also plate haptic lenses. The IOL formulae was again detailed by Dr. Sanjali, so I'm going to move forward from that directly into the management options. Now, how do you actually manage the refractive surprises after cataract surgery? So the main broad two options are of course non-surgical, where you can give the patient spectacles or contact lenses, but we'll be focusing more on the surgical treatments, which can either be cornea-based or lens-based. Now the cornea-based procedures that we can do are either PRK, LASIK or SMILE. And the lens-based procedures, if you've put a toric IOL, we'll have to rotate it in case of residual astigmatism into the right axis. We can use piggyback IOLs, piggyback ICLs, do an IOL exchange, or just by smaller maneuvers like an optic capture, we can actually change the residual refraction. So I'll be giving you case-based examples for all of these. Coming to the cornea-based procedures, if the error is less than 2 diopters and if there is no corneal pathology or dry eye, no glare halos or other photic phenomenon, you can go for cornea-based procedures. Now, how long after the cataract surgery do you wait until you perform PRK or LASIK? LASIK at least 3 months after the initial surgery, but for both LASIK and PRK, we have to make sure that the manifest refraction is stable before we go for any corneal procedures. Now, lens-based procedures, toric IOL rotation, it's ideal to be done within 2 weeks. So when you call your patients, we call every patient for a post-op 1 week dilated examination and check. The eye trace also has a very nice toric alignment check, which gives you the internal wavefront map, the corneal wavefront map, and the axial map as well. It tells you the current corneal power, the toric lens power, and the current entire eye astigmatism. And it tells you exactly how much of the toric IOL rotation will give you how much of a change in cylindrical power. And it also predicts the post-rotation refraction that you will have if you rotate it by that much. So it's an excellent tool to help you with toric IOL rotation. Now coming to secondary piggyback IOLs, the calculation for this is axial length independent calculation. It's based on a careful manifest refraction. So for hyperopic errors of up to 7 diopters, the spherical equivalent that you refract and see is multiplied by about 1.5. And for beyond 7 diopters, Holiday R formula or refractive divergence formula can be used. Now coming to the piggyback sulcus lens formulae, there are two categories. The patient can either be an underpowered pseudophakic, which is a hyperopic refractive residual refractive error, or an overpowered pseudophakic, which gives you a myopic refractive error. So based on how long the eye is, short eyes, average eyes, and long eyes, these are some different modifications for this spherical equivalent into 1.5. Now coming to which lens to use. Lenses that are used for secondary piggyback IOL implantation are the Rayner Sulcoflex lens. 3-piece silicone lenses can also be used, and the ICL also can be used as a secondary piggyback lens. We need to avoid using 3-piece acrylic implants because these may interact with posterior iris tissue because of the semi-tacky nature, and if these lenses are square-edged, they can also cause iris chafing. Coming to the Sulcoflex lens, this is made by Rayner. It's a single-piece hydrophilic acrylic IOL, 6.5 mm optic and 13.5 mm overall length. It has a round edge. The anterior surface is convex and the posterior surface is concave. And the haptics are posteriorly angulated by 10 degrees, so it sits well in the sulcus. But polypseudophakia has certain complications such as pigment dispersion, pigment between the two lenses, iris transillumination defects, intermittent uveitis, secondary glaucoma, interlenticular opacification, red rock syndrome, and you can see here the stages of red rock syndrome, and you can also get a hyperopic shift. So now let's go on to a few case-based discussions. I was thinking of how to give examples in this session, and I went into the archives of Dr. Sri Ganesh and found some very interesting cases that he's performed over the last 25 to 30 years. And these are some of the cases that I found. This is actually a patient who underwent RK for high myopia, and after that underwent a refractive lens exchange, post which she developed a PCO. So you can see in this patient, first the IOL is separated from the bag. There's a neat trick after the separation of the IOL where the posterior capsulorhexis is done for the dense PCO there. Carefully, the posterior capsulotomy is completed, and this is a Sulcoflex lens. The Sulcoflex lens is implanted into the sulcus as a piggyback IOL. And this patient underwent the same procedure in both eyes, where the piggyback lens was put in both eyes. And on top of being a post-RK patient with a refractive lens exchange and a PCO with a Sulcoflex lens in both eyes, a mini monovision was also aimed for. You can see that the lens sits well, and this is the ASOCT. And post-operatively, you can see that in the left eye, the distance vision is 6.6, and in the right eye, the near vision is N6. So this was a very unique case of managing the refractive error post-operatively. Now, IOL exchanges. Basically, we need to calculate in pseudophakic mode, and the other formulae are the Hill-Vergens and the Barrett formulae that are used. This is one case of a young patient who was a software professional. For this patient, a Technis multifocal lens was implanted, and this patient had poor intermediate vision, which was very disturbing for him. So it was decided to actually explant this lens and implant a Alcon Panoptix lens, which is a trifocal lens. So this is the technique of IOL implantation. Basically, this is the IOL implantation set where there's a micro forceps to grasp the IOL at the optic haptic junction, and a micro scissors is used to cut the IOL 3/4 of the way. The right half of the IOL is brought out through the main incision and rotated out instead of cutting it into half. So this is a very gentle, non-traumatic way of explanting the lens with this particular toolkit. A Panoptix trifocal lens was implanted along with limbal relaxing femto LRIs which were done, and the patient was very happy post-operatively. So this is another case where this patient was a high myope, and a toric multifocal lens was implanted in this patient, which kept rotating because of the back distension syndrome which was happening. So initially, the initial management was the implantation of a CTR, which was put. But still, since this was a plate haptic lens, the rotation of a toric plate haptic lens is much higher in high myopes with the distended bags. So this lens was again explanted. This is the same set of instruments which is used, which is the micro forceps, which is used to grasp the optic haptic junction. This is again cut 3/4 of the way, and the same forceps is used to bring out the plate haptic multifocal lens. The plate haptic lenses come out very easily, more in a more non-traumatic fashion than the regular lenses. This is again a Panoptix toric trifocal which was implanted in this patient, and since this lens has loop haptics, it was well centered and did not show any rotation post implantation of this lens. This is another interesting case where this is again a multifocal plate haptic lens. Plate haptic lenses, there are two ways of explanting them. One is the previous method where you cut it 3/4 of the way. The second is this. First, the optic is released from the bag using an iris repositor, which is a non-traumatic way of releasing the single piece lenses. So single piece lenses are much more difficult to explant than 3-piece lenses because they develop adhesions with the capsular bag. So here, gently using an iris repositor and a dialer in the most non-traumatic way possible, this is done. But here, once the IOL is cut, it's cut completely into two halves. You can see that while pulling out one half, there's a ZD that is seen. So after explantation, the PC is cleaned with a Nightingale polisher because there was a dense PCO there. So it's cleaned neatly with a Nightingale polisher, and after which a CTR is implanted to deal with the ZD there while explanting the lens. After the CTR is put, you can see that the ZD was just about 2 clock hours. So the bag is well distended and intact. So after placing the CTR, the lens is implanted in the bag. Here a monofocal lens is used to complete the case. Okay, so the last case I want to discuss is a very interesting case. This was actually a 50-year-old female ophthalmologist who came for an opinion on refractive correction. This was her refraction -6 in the right eye spherical with -9.25 in the left eye with a little bit of cylinder. She had clear lenses and normal retinal examination in both eyes. This was her topography. So you can see that she has borderline topography. So corneal procedures were refrained from. And the plan of management, since the patient is unsuitable for corneal refractive surgery, ICL was considered. But the anterior chamber depth of this patient was very less, 2.32 and 2.27. So she was unsuitable for even a toric ICL. So the surgical plan for both eyes was femto-assisted refractive lens exchange with implantation of a trifocal IOL with arcuate incision. So the calculated IOL power for the right eye was 15.5, left eye was 11. So 3 weeks post-operatively, she came back with blurring of vision. In the right eye, she had a residual refractive error of -1 in the right eye and a small cylinder in both eyes. So you can see the OCT here. So this is the surgical technique that was performed. The lens here was not explanted. The same incision was opened up using a blunt instrument. After this, the lens was carefully released from the bag. So it's very important to do the adjustments or exchanges as early as possible before these monofocal lenses develop adhesions with the capsular bag, just to avoid trauma to the bag. So here you can see that the dissection is being done with visco as well, which separates the lens from the bag gently. So basically, this is a very innovative approach as to what was done. Basically what's being done here is a posterior capsulorhexis under the existing lens. So a cohesive viscoelastic is injected under the neck to keep the vitreous tamponaded down, and a microrhexis forceps is used to gently create a posterior capsulorhexis. So this is a very tricky technique where one has to have a lot of good surgical skill to perform it under the lens and make sure that there is no vitreous loss by tamponading the vitreous by using a cohesive viscoelastic. So you can see that the posterior capsulotomy is completed. So to deal with a myopic refractive error, basically what's being done here is that the lens is being pushed down into the posterior capsulorhexis and an optic capture is being done with the trifocal lens. It's done very gently and slowly, and the haptics still remain within the bag, and the fluidics are completely reduced and the visco is removed. So this is an unconventional method of treatment, but post-operatively, after 6 weeks, you can see that in the right eye, the spherical refractive error has come back to 0. So just by doing an optic capture and a small manipulation of the lens, it's an excellent way of managing this case. So the take-home message is that prevention of post-operative refractive errors is key. Communication with patients, especially in complex cases that they may require fine-tuning glasses or a secondary procedure to make sure that they don't end up with glasses after surgery, is very important. The algorithm for management, to have a clear algorithm as to what exactly we are going to do if we have a plus refractive error, minus refractive error post-surgery, is also very important to have that mental map of the road that you're going to take. And unconventional options like the last case can also work well. So we must think outside the box. Thank you very much for your patient listening.
Great set of videos, Dr. Supriya, and really covered an entire gamut of cases. Just one thought from the panelists. She was showing, maybe sir was not there at that time, showing a couple of cases of IOL explantation where it is quite fibrosed, the periphery of the capsule. Sometimes we even get these older lenses which have opacified. I find it a easier option to cut at the optic haptic junction, leave the haptics inside, than rather removing them, causing dialysis. Your thoughts on that, sir?
See, basically, some of the hydrophobic lenses, like the Acrysof, are very sticky, and there it is difficult to remove the haptics. If it's a hydrophilic lens, or if it's a three-piece lens, it's so much easier to kind of remove the haptics. So there are different techniques. The technique I like is to use a blunt spatula. You can use a fine iris depositor, go under the capsulorhexis, and then try to do a blunt dissection, separate it to some extent, and then inject viscoelastic. The viscoelastic itself will separate the anterior and posterior capsules, and then you may be able to bring the lens in, the haptic out. So suppose you do not get the haptic out, then don't pull on the haptic, because if you pull on the haptic, you will get a zonular dehiscence, and then you will be in a bigger trouble. So what you can do at that time is just cut it at the optic haptic junction, and then on both sides remove the optic first. When you remove the optic, then there is enough space there for you to see and manipulate. Then you can again go in and try to just remove the haptics. You pull it out tangentially, because sometimes there's a tunnel which is there and it is fibrosed all around. So pulling the haptic radially and trying to bring it out is difficult. But if you can pull it along the tunnel which is there, it kind of comes out. But sometimes in cases like Acrisoft lenses, you may not be able to. If it's a long standing case, then you may not be able to remove the haptic, in which case you can leave it behind. There is no problem, you can leave it behind, and when you put in the second lens, see that the haptics are positioned 90 degrees to this haptic, if in the area where you have opened the bag, and it should center quite well.
Last quick question, sir. That is as a guideline to the audience, because we have, let's say, if there is a residual surprise, refractive surprise, we have the Barrett treatment formula, and it gives us three options: piggyback, IOL exchange versus rotation, or any other option, or even a LVC. Where would you prefer LVC versus a IOL exchange or a piggyback? Any
See, again, you
suggestion?
will have to look at the patient and the condition of the ocular surface. If the ocular surface is good, the patient doesn't have any dry eye, and the corneal thickness and topography is normal, then you can go ahead and either do a PRK or even a LASIK or even a SMILE. Especially if the refractive error is low, then you can do a PRK also, and it should work well. If the refractive error is high, if the ocular surface is not good, then you can look at doing uh, exchange if it's in the early post-op. I mean, if it's within 3 months, then the capsular fibrosis is not much. Then you can do an IOL exchange quite easily. Suppose it is long-standing; it's a few years, and the capsule is completely fibrous. Patient is not suitable for a laser vision correction. Then you can use a piggyback lens or a phakic IOL also to correct the residual power.
That's a very important point, and later periods have putting in a piggyback IOL, and even phakic IOLs with the ICL or IPCL also work extremely well with the as a secondary option for piggyback lenses. I mean, they might be slightly cheaper alternatives to the Rainer, and might be more easily and more quickly available, where sometimes it has to be customized with the Rainer Sulcoflex. You also have add-on lenses which are available from Indian companies also, which are quite effective, and you have both monofocal and trifocal variants which are also available.
There are also dual optic or exchangeable optic lenses where you can actually remove only the central optic, leaving the haptic and the periphery intact, and then exchange it with different IOL power or multifocality. That's also available. Then Professor Pellicaris also has a ring now. It is a capsular ring made of silicon. So you put the ring in and then place the implant. So if it's a toric lens, then rotation is less because of the friction, and then explanting the lens is easier because the bag is kept open. And also he says that because of the pressure against the equator, the lens epithelial cells are kind of lies there, and then the incidence of PCO is very low. But again, this is something new that is being introduced. So there are various solutions. You will have to be aware of the solutions, look at what is best for your patients, and then do that.
What is your take on using a CTR with toric IOLs?
See, there was a concept that using a CTR with the toric IOL will reduce the rotation, but then there are studies which show that it does not make a big difference, because what happens is when you put the CTR, it again opens the bag to some extent. It flattens the bag, but it opens the bag. And then again, the contact is not that good as a collapsed bag. And the friction between the CTR, which is made of PMMA, and the haptic is again not that good. So you can still have rotation. In fact, there was one case where it was a plate haptic lens in a large bag, and then it was rotating. So I put a CTR to see if it stabilizes, but this did not help. It still rotated. So I had to expand it and put a open loop C loop lens, so that it kind of sits against the bag. And many of the lenses today which you are getting, the toric lenses, have roughened haptics, and this roughened haptics kind of have a better contact and more friction with the equator of the lens, like the Technis Toric 2 and the Hoya also. And we find that the incidence of rotation is less with these lenses.
Some of the newer lenses also have a larger angle between the optic and the haptic, so that the contact between the haptics and the bag
Right.
is increased these days.
Are there any questions from the audience regarding biometry or formulae or implantation of toric lenses? We still have a few minutes, but if there are no questions, I think we will conclude the session. And I would like to thank all the speakers for their excellent talks and the audience for their patient hearing. And I hope you will take away a few points to implement in your practice. Thank you very much.